When a patient is admitted to a ward, the immediate influx of raw data is overwhelming. Vitals, scattered medical history, demographic details, and lab results hit the desk all at once. Making sense of a patient requires capturing these isolated fragments and snapping them into a structured framework. Clinical assessment relies on translating this scattered biological and behavioral data into a cohesive, actionable care plan. Treating any of these data points in isolation creates blind spots. A recorded drop in fluid intake might seem minor on a chart, but without connecting it to skin elasticity and mobility metrics, a care team can easily miss a severe, impending vulnerability. To build a complete profile, we use a clinical assessment matrix. This relies on 4 specific pillars: baseline biometrics, standardized risk stratification, internal biochemical testing, and developmental contextualization. A highly effective nurse uses these physical metrics and psychological stages to actively anticipate and prevent patient harm, rather than simply reacting to it once it occurs. The result is a living, multidimensional profile, the baseline record used to calibrate subsequent care. We construct the first quadrant of this matrix by establishing the patient's physical geometry and baseline biometrics. Gathering routine height and weight provides the mathematical scaffolding for care. These figures are required to calculate the body mass index, or BMI, and they dictate the precise dosing of high-risk medications. Often, standing height assessments are impossible to capture. A patient may present with severe traumatic injury, advanced age-related skeletal issues, or profound physical disability. This diagram demonstrates the clinical proxy used in those scenarios, the ulna length measurement. The arm is positioned at a 90-degree angle across the chest, measured from the olecranon process at the elbow to the styloid process at the wrist. Once the static physical geometries are recorded, the assessment shifts to tracking dynamic physiological processes through the 24-hour fluid balance chart. Regulating homeostasis requires strictly categorizing every milliliter of fluid entering or exiting the body to prevent life-threatening fluid overload or severe cellular dehydration. This fluid balance table divides physiological traffic into 2 heavily monitored streams. Intake tracks oral, intravenous, and subcutaneous fluids, while the output column captures the precise volume of urine, vomit, nasogastric aspirates, and wound drainage. Height and weight lock in the physical scaffolding. Strict fluid monitoring reveals the real-time physiological stability operating within it. With the baseline established, the matrix shifts from passive data collection to the active anticipation of physical harm, beginning with skin integrity. Clinically, pressure injuries are defined as localized tissue damage resulting from prolonged pressure, shear, or friction, typically occurring over bony prominences. The damage is driven by ischemic hypoxia. When tissue is compressed, localized capillary beds are crushed. Blood flow stops and the tissue rapidly necroses. This diagram maps the high-risk anatomical sites based on common resting positions. Whether a patient is supine, lateral, prone, or sitting, the gravitational force focuses heavily on specific vulnerabilities, particularly the sacrum, heels, and scapula. Because of how quickly ischemic damage compounds, hospital protocols mandate a comprehensive head-to-toe skin examination within the first 8 hours of admission. This is the Braden scale. It is the primary clinical tool used to standardize the assessment of pressure injury risk by measuring physiological and behavioral precursors, specifically sensory perception, moisture exposure, and baseline activity levels. The scale uses an inverse scoring logic. A lower numerical score indicates a higher state of vulnerability. Any total score dropping below 9 flags the patient at a very high risk for imminent tissue breakdown. By grading these variables, the Braden scale transforms subjective visual observation into an objective, preemptive data stream. The second major vector of anticipated harm in the matrix is patient mobility and the specific risk of falling. The World Health Organization strictly defines a fall as any event resulting in a person inadvertently coming to rest on the ground, floor, or other lower level. This document is the Falls Risk Assessment Tool, or FRAT. It begins with a risk status screen scoring recent falls and medications, then moves to a detailed risk factor checklist evaluating vision and mobility to generate a targeted action plan. To maintain accuracy, this screening must be executed on admission, strictly every 7 days of the stay, or the moment the patient's medical condition changes. The FRAT mandates a baseline of minimum safety interventions for every single patient, but a high-risk score triggers highly individualized intensive defensive protocols. Much like the skin integrity scales, falls risk assessments are active defense mechanisms. They are designed to neutralize frailty before a catastrophic incident can occur. With the external physical risks calculated, the assessment matrix moves deeper, requiring an internal biochemical data layer. The chemical reagent strip, commonly known as a dipstick, provides immediate microscopic verification of the patient's macro-level physiological status right at the bedside. This evaluation chart provides the visual mapping system to interpret the dipstick. The top rows evaluate renal function, like specific gravity for hydration and pH for acidity. Lower rows flag internal conditions, leukocytes for infections, and ketones for diabetes. This table translates those raw lab values into clinical action, directly correlating the visual reagent results to required nursing considerations and diagnostic next steps. Urinalysis acts as the biochemical verification layer. It either confirms or directly challenges the assumptions made during the fluid balance tracking and the external physical assessment. We reach the final, enveloping layer of the matrix, establishing the patient's developmental reality. While genetics dictate roughly 80% of a person's physical traits, environmental factors, family norms, and socioeconomic status heavily influence how health and disease actually manifest in the individual. Raw clinical data cannot be treated in a vacuum. A heart rate and a Braden score must be mapped against established psychological frameworks to effectively tailor the way a nurse interacts with the patient. This is Maslow's hierarchy of needs. The pyramid dictates that base physiological stability, oxygen, fluids, and temperature, along with immediate safety, must be entirely secured before higher-order psychological or esteem needs can be addressed. This circular diagram outlines Erikson's stages of psychosocial development. Managing continence in a toddler requires navigating autonomy versus shame through encouragement, while the exact same physical issue in an older adult sits in integrity versus despair, prioritizing personal dignity. Similarly, knowing where a patient sits within Piaget's stages of cognitive development strictly dictates how a nurse must communicate instructions, explain reasoning, and secure consent. Understanding these developmental stages is what allows a clinician to calibrate standard physical assessments to the actual human being lying in the bed. We have built the profile through the 4 quadrants, establishing physical dimensions, layering systemic risk, verifying internal biochemistry, and adding the psychosocial context. The true power of the clinical assessment matrix lies in recognizing how these seemingly isolated data points trigger cascading effects across the entire patient profile. A drop in fluid intake triggers a chain reaction, concentrating urine and elevating specific gravity. This dehydration alters skin elasticity, lowering the Braden score and increasing pressure injury risk. This high-risk status mandates physical interventions tailored to the patient's cognitive stage. True clinical assessment is never passive data collection. It is the active anticipatory synthesis of biology and behavior. Mastering this multidimensional matrix provides the clarity required to stop reacting to symptoms and begin executing preemptive, comprehensive clinical care.